respected chairpersons, and my dear friends, it is my honor and privilege to stand before you and present on sports injuries of shoulder. So, coming to the topic proper, we have heard today about the dynamic stabilizers. Remember the dynamic stabilizers? The static stabilizers, you know about the muscle portion, the bone portion. Regarding the dynamic stabilizers, they get to see that the shoulder is involved in variety of activities, and that includes the force couples. The important force couples include the subscapularis and infraspinatus force couple, and the second one, that is the trapezius, the upper trapezius, lower trapezius, and serratus anterior. That force couple that is very important in elevation and other activities, abduction activities. Just a word about the weights or the body forces. If suppose the weight of the upper extremity is termed W, it is around 7 times the upper extremity weight. That is the load at the glenoid labrum. At the load at the glenoid labrum, it is around 6 times, or at the deltoid pull, 2.5 times at the supraspinatus and 5 times at the subscapularis and other internal rotators. And injuries, there is no sports without injury. Okay, and the shoulder is injured in almost all sports. Even though hockey is our national sports, we pride ourselves in being the best in the world of cricket. Okay, so in cricket injuries, apart from the body injuries, we have a lot of soft tissue injuries, etc. And can we identify what this is? This is how you take up the kinematic data and the force analysis. And this is the only ICC recognized center in India. Can anybody identify where this center is? The center is at one of the southern states of India. It is in our neighboring state. Tamil Nadu SR Medical College, Sri Ramachandra Institute and Research Center. They have got more than 20 cameras to record the bowling action. Okay. So why this damage to the shoulder occurs in cricket and other sports, overhead sports? Mainly you have to remember about 5 things. One is the biomechanics of bowling, biomechanics. Then about the impingement, the internal and external impingement, bursitis, hypertrophy, etc. That is the rotator cuff causes. One is the altered biomechanics of bowling. Second is the rotator cuff causes. Third is the biceps tendon and the slap tears. Fourth is the GIRD. GIRD means glenohumeral internal rotation deficit. And the fifth one is the then scapular dyskinesia, scapular kinetic abnormalities, and the sixth one is the laxity or the hypermobile or mobility of the joints. So coming to the different kinds of bowling action, people can bowl with the left hand as well as right hand. What is this person doing? He can bowl with both hands. What do you call such a person who can bowl with both hands? Ambidextrous bowlers. So to promote what are the different types of bowling action, bowlers, how many different types of bowlers are there basically, classification? Fast bowlers, everybody's favorite fast bowlers, and spin bowlers are there. What's the difference between the two? So I invite Dr. Amal, who is a first year PG in the Govt Medical College in Trivandrum, to come forward. So he said he can demonstrate about the bowling action. Can Amal please see? I was wondering where he was. He is basically a spin bowler, so you can see the technique how he spins. So that is a spin bowling action. What the difference between the fast bowling and spin bowling is? Spin bowlers, they tend to control the ball after it leaves the body. Okay, so they can use it at the wrist and fingers. They can play with the wrist and the fingers. So you look at his wrist and that is the wrist action. You can see the wrist action, or you can do the finger action. Right. Okay. So regarding the fast bowling, can you show? So coming to the fast bowling, the phases of, anybody can volunteer to tell us about the phases of his bowling action? Can you do it once again? See the leg placement, see the leg placement, see the leg placement, see the body torso. So he is actually bowling in the front way. So sometimes the persons will bowl with the sideways also, sideways, and there is a follow through action. So basically this is the phase. The one is the pre-delivery phase. Second is the mid-bound, back foot contact, front foot contact, ball release and follow through. So can you do it once again? Yeah. So this is that is the maximum when it is a ball is in the upper portion, that is in the back foot contact, between back foot and front foot contact. Then there is a ball release and then always there is a follow through. This follow through can occur sideways or in the front. Okay. So in the sideways, this is what happens. This is what occurs. Thank you, Dr. Amal. I probably have to okay. Cricket player. So coming to this, the maximum, the shoulder, what happens in the shoulder is thrown from a period of flexion and elbow at the flexion. The shoulder is going into circumflexion through extension, abduction, external rotation and thrusting flexion and then finally internal rotation. So the damage can occur at any phase and chronic overuse can lead to many shoulder injuries. So there is an X-ray of a player. Is there anything abnormal here? And anything abnormal here? Actually you don't see much, but if you look carefully in this region, this is the clean out C. Always at the X-ray, take care to see this region. Usually there may be an associated injury. What is this injury? Today morning there was a class on radiology and this is an example of a Bankart lesion. Bankart lesion can be a bony or soft tissue. So here it is a bony, this is a soft tissue, that is a labrum injury, inferior labrum. Here is a bony Bankart. Bankart has got many different variants. I am not going into details. Apart from the Bankart lesion can be associated with what? Dislocation, anterior inferior dislocation, or can lead to a, if there is a Bankart lesion and a Hill-Sachs lesion, there is a propensity for chronic dislocation of the shoulder. Then slap tears occur. Okay, so this is in upper portion. Slap tear is what's the full form of slap? This class is mainly for the PGs. Full form of slap is superior labrum anteroposterior injury. Okay, so that occurs in the 10 o'clock to 2 o'clock position, while the Bankart lesion you look at the 3 o'clock to 6 o'clock position. So in the slap region, you know the biceps origin area, and this is intimately associated with the supracranial tubercle and the biceps. Today morning they told us about the 10 different types, mainly 4 different types are there. In the first one, you can see that there is fraying, at the origin of the long head of biceps, and there is a tear there, supralabial tear, but it is not avulsed. The second one, the fraying is little more, and it is little partial avulsion at the region. And the third one, there is a bucket handle tear. This is a bucket handle tear. The rim, glenoid labrum rim, that detaches itself partially like a bucket handle. And the fourth one, it is a bucket handle together with a long head injury. So in the fourth and the third one, the first and two you may opt for a conservative management, but most likely in the third and the fourth one you may have to go for an endoscopic correction with an embedded screw. So this is what you find here. This is actually a player who had sustained an injury to the shoulder, and on ultrasound examination the infraspinatus showed hyperintensity and all, and they suspected not a partial tear but a tendinitis, and he was given rest NSAIDs were given and became symptomatically much better. Then he started playing again. So instead of being a bowler, he decided to field. So on field he took a catch and he was symptom free for that, but when he tried to throw after the catch, then he suddenly felt excruciating pain, and then they did an X-ray and a CT scan that showed an avulsion of the coracoid. So remember, we are using a lot of ultrasound to diagnose shoulder injuries, but sometimes when you use ultrasound you may miss bony injuries. Okay, so avulsed cord, and in young patients always see that the clavicular stress fractures are also identified. Little shoulder, that is called clavicular stress fractures. Then coming to what happens in the shoulder in cricket throwers and in overhead activities like baseball and other activities is that the internal rotation is limited and there is more amount of external rotation. This is called GIRD, glenohumeral internal rotation deficit, but it is symptomatic, it is more important if the total amount, so total it is around 180 degrees, the combination of internal rotation and external rotation. In a normal person, suppose it is like 110 degree, it is changed to 110 degree of internal rotation, it's more than normal, and internal rotation is only 70. Then also you shouldn't consider this as abnormal, because the total amount is total internal rotation plus external rotation is still 180. Okay. So at the same time, this is taken pathologic if the internal rotation deficit is and the total is not amount to 180 degree. If it is less than 180 degree. Okay. So it's a normal, if a normal person has got a 110 degree of external rotation, 70 degree of internal rotation, and a person, cricket thrower, has got only a 45 degree of internal rotation but 135 degree of external rotation, do not take it as abnormal. Okay. But it is symptomatic or it is taken abnormal if the total internal rotation, external rotation is less than 180. So that is regarding the, and coming to the impingements. Moving in. Coming to the impingements, it can be, what is the difference between internal and external impingement? The external impingement occurs in this subacromial region, like bursitis or hypertrophy, etc. And in internal impingement, it is due to the hyperabduction and the extension at the shoulder. So what happens is the supraspinatus and infraspinatus get impinged in the posterior region. The posterior region is also called a posterior-superior impingement, internal impingement. So when you do this test, this is apprehension test. When you do the apprehension test, the patient will point towards the area of pain as the posterior one. Okay. The other type of impingement, it is the anterior one, or in usual impingement test will be positive. Here in internal impingement, the near test will be positive or negative. Job test or the MT-CAN test. MT-CAN test will be negative in cases of internal impingement or posterior impingement. The relocation test is positive. What is relocation test? The shoulder, when you try to posteriorly glide, the pain will disappear. Okay, that is called the relocation test. So the methods to prevent will be to correct the faulty technique, adequate warm-up, rotator cuff strength, and strength conditioning of the lower body. Lower body condition is important is because the patient is making, or a bowler is making, an arc of motion. The follow-through is also there. So the whole momentum is transmitted onto the ball. So any overhead sports, in addition to the shoulder, you have to strengthen the torso as well as the lower body also. So what is this that you find here? A person swimming with the shark, that is a tiger shark. This you can do in Philippines. Do you know the person? I will give you a clue. He is a physiatrist. Very young, very athletic physiatrist. Some of the people from Kannur will know him. He is Dr. Sabir. He is a contract SR in our department at Kannur Medical College. And he is an avid swimmer also. The swimming, different types of swimming, everybody knows about this. The front crawl is otherwise called a freestyle swimming. Then backstroke, breaststroke, and butterfly. In swimming, there are three different phases, that is called the glide, pull through, and recovery. In the glide, the anterior and middle deltoid, upper trapezius, and rhomboids are more active. Swimming, is it an open kinematic exercise or a closed kinematic exercise? We all feel that it is an open kinematic exercise, but actually swimming is considered closed kinematic change because the fulcrum, the hand is supposedly stationary and it is like a body is thrown over the hand. Okay, so that is why it is called the endpoint is kept stationary and the body is moving forward. That is why it is classified under closed kinematic chain exercise. So the glide and reach, the early pull through, mid pull through, late pull through, end of pulling, early recovery, mid recovery, late recovery. So almost all the periscapular muscles are involved, starting with the anterior and middle deltoid, then pectoralis, serratus, latissimus, subscapularis, suprascapularis. Some of the muscles will act eccentrically. For example, the early pull through, there is pectoralis major and then pectoralis minor. In swing moves, what happens is usually the pectoralis minor will be shorter. Pectoralis minor will be shorter. Okay. So it is like there is a thing called a pectoralis minor index that is in comparison with the body height. Okay. So rehabilitation of all these overhead injuries consists of a rotator cuff strengthening, stretching, the serratus and supraspinatus and infraspinatus. Dr. Amel, can you come forward just once? So some of the exercises are the arm twist. Can you show us this one? Arm twist like this. That is it. Raised arm twist. You can see that raised arm twist. Then this is called a half bow and full bow. In half bow, it comes like this. This is a half bow. This is half bow. When it comes like this, this is called a full bow exercise. Then elbow to the torso, and if you go behind, that is called a posterior capsular stretch. And elbows in. Then shoulder swings. This is a shoulder swing. You can use a TheraBand for the shoulder swing. And so this is if you connect it to something and you can just pull. This we just try. We can always try the isometric exercise. We always start with isometric exercises and then TheraBand pulling exercises with that. So this is the TheraBand rotation. If there is another ball or something like that, you can pull it. Yeah, you can pull like that. TheraBand exercises, TheraBand rotation exercises, and the Y raise. This is using a medicine ball. If you are able to rise like this. They say that at the end of your treatment program, the person should be able to perform this pain-free. Thank you, Doctor. This is called as spiking. Okay, in a pongite tarot adikina, that is called as spiking. So that is a kind of injury that you can sustain at the shoulder. And volleyball, some other thing for overhead activity is like the six scapula syndrome. What is this six scapula syndrome, SSS? What are the components? There are 4 components. I'll give you a clue. 6 scapula, SICK. Jijit, can you venture? First rank holder, can you venture? Please. 6 scapula. കേൾക്കുന്നില്ല ഇങ്ങോട്ട് പോയിരുന്നില്ല വിന്നി can you help? So 6 scapula is scapula malposition, inferior medial border prominence, coracoid pain and malposition, and kinesis abnormalities of the scapula. So the scapula, what happens here is patient can present with an anterior coracoid pain, posterior superior localized pain, or superolateral pain. Here the scapula is forward tilted, protruded, and there is a dropping of the shoulder. And you can test it by scapular retraction test and by scapular assistance test. And some of the exercises include, this is a levator scapula stretches. This is something that is usually not done. So can anybody interested can participate in this stretch. What you have to do is, you have to keep your hand like this. Anybody? And with the opposite hand, you pull your head forward. And you can feel the stretch of the levator scapula. That is how you do the levator scapular stretches. So this is one of the exercises of periscapular stretching. Levators, rhomboids and pectoralis minor get tight. All the other things get loose. Okay. Overhead wall rollout is one type of exercise. Another is isometric extension. You push over the mat with your elbows in and you can feel the scapula turning inwards medially. Then horizontal band fly using a TheraBand is also can be done by just make a loop with that TheraBand, take it behind. This is called a horizontal band fly. Can you show them? Another thing is hover. Sometimes you may have to take it out after ultrasound guidance. This is a position for that. The vertebral border, the inferior angle, and the direction of the needle is like this. And we can enter the subscapular space and take out the fluid there. Okay. So in 2001, Dr. Biju Govt had presented a paper showing this. What is the abnormality here? Infraspinatus palsy in a volleyball player in Calgary. While he was at Calgary, he had presented here in Rwanda. So which nerve is involved here? Suprascapular nerve at which region? The commonest one in overhead athletes is this region, the sphenoglenoid notch, at the sphenoglenoid. At the same time, in rotator cuff avulsion or rotator cuff tears, then also suprascapular nerve palsy can occur, but that occurs more proximally. In overhead athletes, it's usually the lower portion. So I come to the end of the talk, and this is what is driving us. Success is where preparation and opportunity meet. So I congratulate our organizers for making this conference a huge success, because here you had prepared well and you had an opportunity. So thank you very much.